Welcome to our video on uncomplicated UTI, complicated UTI, and cystitis. Let's get started. Before discussing individual topics, let's first go through the classification of urinary tract infections, or UTIs. UTIs are classified into lower and upper UTIs. The lower urinary tract is comprised of the bladder and urethra, whereas anything above the bladder is part of the upper urinary tract, which includes the ureters and kidneys. Hence, lower UTIs include infections of the bladder, which is known as cystitis, and infections of the urethra, which is known as urethritis. Upper UTIs include infections of the ureters and infections of the renal parenchyma, which is known as pyelonephritis. All right, with this in mind, here's our overview slide, and let's begin by discussing uncomplicated UTI. Generally, a UTI is considered uncomplicated when it occurs in non-pregnant, healthy, immunocompetent females. It's also confined to the lower urinary tract. Patients have no underlying structural or functional urinary tract abnormalities. There are no other underlying predisposing factors, such as indwelling catheters, and when it also responds to therapy. Next, let's discuss complicated UTI. A UTI is considered complicated when it's associated with an underlying metabolic or structural abnormality, or when it has a high risk of progression to pyelonephritis and sepsis. First of all, a UTI in men is always considered a complicated UTI. As we'll discuss in the coming slides, the majority of UTIs occur when fecal flora that colonize the perineum ascend up the urethra and infect the bladder. Because the male urethra is very long and also the urethral opening is at the tip of the penis, far away from the perineum and the anus, UTIs are uncommon in healthy males without underlying predisposing factors. Therefore, any UTI in a male is considered complicated and warrants further urologic workup. Secondly, UTI in pregnant women, diabetics, immunocompromised patients, and hospitalized patients is considered complicated because all of these states are associated with a higher than normal risk of progression to pyelonephritis and urosepsis. UTI associated with structural or metabolic abnormalities are also considered complicated UTIs. Examples include vesicoureteral reflux and urinary tract obstruction. Recurrent UTI also suggests an underlying predisposing factor and is therefore considered complicated. Upper UTIs are considered complicated UTIs because these are associated with a higher risk of progression to urosepsis and renal failure. Lastly, any UTI complicated by sepsis, known as urosepsis, is also a complicated UTI since sepsis is always associated with significantly raised mortality. All right, now let's move on to discuss cystitis. With regards to cystitis, we'll be discussing general features, risk factors, the etiology, clinical features, diagnosis, and treatment. Let's start with some general features. Cystitis is infection or inflammation of the bladder. It can have both infectious and non-infectious etiologies. Acute bacterial cystitis is the most common cause of cystitis, and the majority of cases are caused by ascending infection by fecal flora, which normally colonize the perineal skin. Other much less common causes of cystitis are hemorrhagic cystitis, which can be caused by adenovirus or drugs such as cyclophosphamide, as well as radiation cystitis and chemical cystitis. All right, let's talk about some risk factors. Female sex is a major risk factor because UTI is much more common in females than males. This is because females have a shorter urethra, and it's also closer to the anus when compared with a male urethra. This makes it easier for bacteria to ascend to the bladder in females. Sexual intercourse also increases the risk of UTIs, as this helps propel the bacteria into the urethra. Other risk factors include urinary catheterization, pregnancy, diabetes, and immunodeficiency states. Urinary retention, such as that due to urolithiasis, benign prostatic hyperplasia, or neurogenic bladder, also significantly increase the risk of urinary tract infections because bacteria are not flushed out regularly. The most common causative agent is E. coli, which is present in about 80% of cases. Staph saprophyticus is the second most common cause in sexually active young women after E. coli. Enterobacter, Citrobacter, Pseudomonas, Staph aureus in Canada are seen in hospitalized patients and are uncommon in otherwise healthy individuals. Urease-producing organisms such as Proteus and Klebsiella also cause UTI. The breakdown of urea by these organisms and subsequent release of ammonia make the urine alkaline, and this alkaline pH also favors precipitation of ammonium magnesium phosphate stones, which may form large struvite stones. This is a gram stain of E. coli, and notice that we're seeing pink gram-negative rods. Here's a gram stain of Staph saprophyticus, and we can see clusters of gram-positive cocci. This is a gram stain of Proteus mirabilis. Similar to E. coli, it appears as gram-negative rods. This is an X-ray image showing a struvite stone. These are composed of calcium, magnesium, and phosphate and precipitate in alkaline urine. Therefore, they're associated with urease-producing organisms such as Proteus, like we discussed earlier. Okay, now let's discuss some clinical features of cystitis. The inflammation and irritation of the bladder wall gives rise to the common symptoms of cystitis. These include dysuria, urinary frequency, urinary urgency, suprapubic pain and or tenderness. Sometimes hematuria or blood in the urine may be seen as well. And finally, it's important to note that fever is characteristically absent, which helps us distinguish it clinically from pyelonephritis. The diagnosis of cystitis and other UTIs are usually made on urinalysis. To avoid contamination with the normal flora or perineal skin, the specimen is collected from the midstream of urine, which directly comes from the bladder and has the highest likelihood of being sterile. This is what we mean by a clean catch midstream specimen. Urinalysis of a patient with cystitis shows pyuria, defined as more than 10 white blood cells per millimeter to the third power. Another important thing to talk about is white blood cell casts. These are cylindrical structures that form when these cells pass through the distal tubules of the kidneys. Hence, urinalysis of cystitis shows no casts because the white blood cells are coming directly from the bladder and don't pass through the kidney tubules. Opposite is the case with pyelonephritis, in which the white blood cells come from the kidney, pass through its tubules, and form casts. Unless the specimen is contaminated, the presence of any bacteria on urinalysis is considered abnormal because urine is supposed to be sterile. So bacteriuria of any number supports infection. A patient with cystitis may also have mild proteinuria and hematuria. A high epithelial cell count suggests contamination of the urine sample. A pH of more than 8 suggests infection with urease-producing organisms such as Proteus. Finally, a gram stain is done on the urine sample to help identify the pathogen and determine appropriate antibiotics against it. A dipstick test can quickly assess the urine and is widely used as a screening test. Esterase is an enzyme released only from white blood cells, and so positive esterase indicates the presence of white blood cells. We also look for the presence of nitrites. Normal urine contains nitrates. Gram-negative bacteria produce nitrate reductase, which converts these nitrates into nitrites. Hence, a positive nitrite test indicates the presence of gram-negative bacteria in the urine. A urine culture is the gold standard test to diagnose a UTI in a symptomatic patient. However, this is not used in uncomplicated cystitis, which is usually diagnosed and treated based on typical symptoms and the result of a urinalysis. Nonetheless, if a urine culture is done, the presence of greater than 10 to the 5th power colony-forming units per milliliter of a single organism is diagnostic of a UTI. Blood cultures are also done in some cases. Common indications include very ill patients, for example those with deranged vitals, and when urosepsis is suspected. UTIs are uncommon in healthy males with no metabolic or structural abnormalities of the urinary tract. Hence, urologic workup should be done in any man with a UTI. Here's an image of a urine specimen showing numerous white blood cells. All right, let's try a question. A 22-year-old sexually active female presents to the office with complaints of burning micturition for 2 days. A urine esterase test is positive. Urine culture grows colonies of coagulase-negative gram-positive cocci. What is the likely infectious agent? So this is a patient with symptomatic urinary tract infection as shown by burning micturition and urine esterase positivity. The most common cause of UTI in a young female is E. coli. However, the urine culture is showing coagulase-negative gram-positive cocci, confirming infection with Staph saprophyticus, which is the second most common cause of UTI in a sexually active female. All right, let's move on to treatment. In the case of acute, uncomplicated cystitis, the majority of cases can be treated on an outpatient basis. Empiric antibiotic treatment is based on the results of a urinalysis and gram stain. Oral trimethoprim sulfamethoxazole for 3 days is the most commonly used treatment. Common alternatives include nitrofurantoin and fosfomycin. Improvement is usually observed in 48 to 72 hours if the appropriate antibiotic is given. Urine culture or further workup is indicated if no improvement is seen after 72 hours of therapy. Definitive identification of the causative organism and its resistant pattern on urine culture and sensitivity can help guide the appropriate antibiotic coverage and help improve symptoms in many of these unresponsive cases. For complicated cystitis, urine culture and sensitivity is required to guide antibiotic treatment. Fluoroquinolones is the first-line treatment in most cases. Treatment duration is of 5 to 14 days depending on the clinical response. It's also important to address underlying abnormalities. For example, appropriate imaging and urologic workup is performed if there is suspicion of structural or functional urinary tract abnormalities, and then treatment is done accordingly. For example, we may need to relieve obstruction to treat urinary retention. Some patients with cystitis need inpatient management. Examples include very ill, elderly, immunocompromised individuals, as well as those who are vomiting and so cannot take oral antibiotics. Additionally, those requiring hydration, for example, hypotensive patients, and those requiring intervention, for example, patients with an obstruction. In hospitalized patients, we usually take blood cultures and start IV antibiotics. IV fluids are given to dehydrated patients. Patients are then switched to oral antibiotics after 48 hours of clinical improvement. All right, let's wrap up with a final question. A 25-year-old female presents to the clinic with burning micturition for several days. She also reports urinary frequency and urgency. The physical examination is normal, including an absence of fever. Laboratory results show positive leukocyte esterase, positive nitrites, pyuria, an absence of casts, and the presence of gram-negative rods in the urine. What is the best next step in the management of this patient? A. Urine culture. B. CT scan of the abdomen. C. CT scan of the pelvis. D. Prescribe oral trimethoprim sulfamethoxazole. Or E. Admit the patient. So this is a patient with classic symptoms of a UTI, including burning micturition, urinary frequency, and urgency. The absence of fever favors cystitis over pyelonephritis. Positive leukocyte esterase suggests pyuria. A positive nitrite test suggests infection with gram-negative rods. Pyuria with no casts, again, favors cystitis over pyelonephritis. In addition, visualization of gram-negative rods in the urine further supports the diagnosis of cystitis in this patient. With such a classic presentation and supportive urinalysis results, a presumptive diagnosis of cystitis can be made, and empiric antibiotic therapy against gram-negative rods should be started without any urine culture or imaging. So the next best step in the management of this patient would be to prescribe oral trimethoprim sulfamethoxazole on an outpatient basis. So the correct answer is choice D. Recall from this slide that patients with acute uncomplicated cystitis can be treated with TMP-SMX. Now let's discuss why the other answer choices are incorrect. A is wrong because a urine culture is not indicated in a patient with uncomplicated cystitis. It's usually reserved for patients who do not respond to treatment or who have other features of a complicated UTI. B and C are wrong because imaging is not indicated in a patient with uncomplicated cystitis. Again, this is considered in patients who do not respond to treatment, are suspected of having an obstruction, or have other features of a complicated UTI. E is incorrect because this patient is a young, healthy, stable female and her physical examination is normal. She is likely to respond to oral antibiotics on an outpatient basis and there is no indication for hospitalization. So again, the correct answer is D. Prescribe oral trimethoprim sulfamethoxazole. And that concludes this section.